Thank you for joining, everyone that has joined. We will wait for the others to join and we will start at the top of the hour. Thank you. Good morning, good afternoon. We will be starting in the next 3 minutes, please. Thank you. Thank you, Amarach. You can share the slides now, and we will begin in the next 1 minute.
Marathi, can you turn on my video? I couldn't do that from my side.
Robert, please unmute.
Thank you. Good morning. Good afternoon, colleagues. Welcome to this webinar on strengthening cholera response in Africa in the context of evaluating the 717 targets. My name is Robert Ngune. I am an information management consultant with the Risk Analytics and Action Reviews Unit in WHO HQ. I am your moderator today, together with Alan Pyro, who is a technical officer, risk management and preparedness in AFRO, who will also moderate together with me, and he will come in during the Q&A session. Next slide, please. Before we begin, please note that the virtual webinar meeting adheres to the Code of Conduct to prevent and respond to sexual misconduct, including sexual harassment, abuse, and exploitation. Next slide, please. So this webinar introduces a critical project that is focused on evaluating the effectiveness of the 717 timeliness targets for cholera control in the WHO Africa region. The goal of this webinar today is to engage with the national and subnational technical teams and partners from the affected countries, particularly during 2022 and 2023, to ensure collaborative participation in this important initiative. By sharing project details and emphasizing the importance of stakeholder involvement, we hope to foster a collaborative approach to improving cholera response across the region. And therefore, the key objectives of this webinar is to explain the importance of the 717 targets in the context of early action reviews. And then we'll introduce the project, the objectives of the project, the methodology, and the key stakeholders. And we also hope to secure an active participation from national and subnational teams in data collection that will follow. And then we hope to foster a collaborative network of stakeholders that are committed to improving cholera response in the region. And then at the end of it, very importantly, we want to identify the focal points from the national teams that will be involved in the service, and we're able to explain their roles and their responsibilities and what they will be doing as the part of the next steps. Next slide, please. So with us today in the agenda is the project team that consists of the following. We have Dr. Charles Juguna, who is the Regional Advisor, Country Readiness Strengthening in the AFRO. And then we have Dr. Nimo Kando, who is the Unit Head for Risk Analytics and Action Reviews Unit at the WHO Health Emergencies Program, Headquarters. We have Landrin Trico, who is a technical officer in the same unit, Risk Analytics and Action Reviews. We have Cynthia Bell, who is a technical officer in the same unit, Risk Analytics and Action Reviews. We have Fred Kapaya, who is an epidemiologist cholera control in APRO. And then we have Peter Mala, who is an epidemiologist, risk analytics and action reviews as well. Next slide, please. So as part of the housekeeping, the interpretation is there in English, French, and Portuguese. And by clicking the interpretation button, then you can choose the language that you want to listen the webinar in. All the participants have access to the show captions, Q&A, chat, reactions, raise hand functions, and interpretation functions, and you can use them as you deem fit. Your microphone is off, as well as the camera by default, and during the Q&A session, you will be allowed to raise your hand and your microphone will be unmuted to allow you to speak. Next slide, please. So as part of the Q&A session, you will be able to raise your questions using the Q&A feature regarding the topic and the presentation, and the responses may occur live during the Q&A session that will come later in the webinar, and or they will be answered also live, privately and publicly also for the benefit of all the participants. So keep checking whether your question has been addressed. Use the chat feature for connectivity and logistics related queries, but we may also use the chat to share important information. So participants in the meeting, next slide. By attending this webinar, you consent to the permission to record your contribution and then share the recordings for continuous learning purposes. This session recording will be shared to all in the days following this webinar. Next slide, please. So with that said and done, I will now start to call out the speakers. And now I call upon Dr. Charles Juguna to make the opening remarks. Dr. Charles Juguna, you have the floor, please.
Thank you. Thank you very much, Robert. Good morning, good afternoon, ladies and gentlemen. I'm very delighted to welcome all of you to this very important webinar on strengthening cholera response in Africa. Our focus today is on evaluating the 717 timeliness targets. As we are aware, cholera remains a significant public health challenge in the African region. Any country that cannot assure its citizens of access to safe water and sanitation and hygiene, then you can be assured cholera outbreaks will continue to recur. And therefore, cholera is indeed an indicator of social development. When we look at what happened in 2022 to 2023, 17 countries were affected, and they reported over 284,000 cases of cholera and over 5,000 cases, over 5,000 deaths, with a case fatality rate of 1.8%. We know that it's recommended we should not go beyond 1%, but we reported 1.8. Today, we gather to evaluate and discuss the effectiveness of the 717 timeliness target, a metric designed to enhance our ability to detect, notify, and respond to cholera outbreak promptly. So the first 7 is on detection, 1 is on notification, and 7 is on response. Along the way, you'll understand better this metric as we go on. The project aims to provide evidence on how International Health Regulations 2005 capacities in preparedness and readiness can improve outbreak management and the effects of meeting the 717 timeliness targets during cholera outbreaks. The 717 timeliness targets provide a structured approach to outbreak management, ensuring that we can swiftly identify and address cholera cases to prevent widespread transmission. The overall goal is to evaluate the impact of improved timeliness on outbreak outcomes and determine the capacity building improvements needed to support the 717 goals. Our discussion today will focus on the 717 metric and its successful application to manage a cholera outbreak. These discussions will highlight the importance of preparedness, timely detection, and coordinated response efforts in mitigating the impact of cholera outbreaks. We need to further explore the enabling factors that contribute to the successful implementation of the 717 targets, as well as the challenges that we face while implementing these targets. By understanding these elements, we can identify best practices and areas for improvement, ultimately strengthening our collective response to cholera and other public health threats. I encourage all participants to actively engage in the discussions, share their insights, and collaborate on developing strategies to enhance our cholera response capabilities. Together, we can make significant strides in protecting our communities and ensuring a healthier future for all. Thank you very much and welcome.
Thank you indeed, Charles. And now I want to call upon Amaracha Bianuru, who's a training officer based in the WHO Africa Regional Office, to run a short poll just to gain your understanding of the 717 timeliness targets. Over to you, Amaracha. I hope everyone has taken the poll.
Yes, Robert, we have 79 people who have responded currently, and people are still responding. We have about 2 more minutes and then I'll close the poll.
Okay, thank you.
Over to you, Robert.
Thank you, Amarachi. And right now, I want now to call upon Dr. Nimo Kando to make his remarks and also present the overview of the project and alignment with the WHO goals. Dr. Kando, you may take the floor. Next slide.
Next, I think this is Charles' presentation, not mine. So over to you, Charles.
Charles Kodia. Sorry, Nimo Kando. Dr. Charles Kodia, you may take the floor on the importance of timely response and the 717 target. Thank you. Apologies.
Okay, that's okay. Can you project the next slide? Good. Let me ensure that I can see the whole slide. That's okay now. Yeah, again, colleagues, welcome. I'll take you through a few slides about the situation of cholera in our African continent. And this is beyond Africa. If you look at the map on the right, you'll see that issues of cholera outbreaks have affected many WHO regions, Africa, EMRO, and also the Southeast Asia region. In 2022, 44 countries reported cholera cases, and that was an increase of 25% compared with 2021. And you may be aware that in 2023, cholera was declared by WHO as a grade 3 emergency. That is the highest ranking in terms of grade that we can give an outbreak. These outbreaks, we have seen them come back very powerfully, and we are seeing more mortalities than before. And there are many people who are dying, not just in hospitals, but also in communities. And therefore, this underscores the need to ensure that we have effective prevention and control strategies. And if things are done in a timely manner, then we can be able to minimize the devastating impact of cholera. If you look at the second map on the right, you'll see again the intensity, the attack rate in African region and the other regions, that we have countries that have had high transmission of cholera. Let's go to the next slide. Yeah, again, when you look at data that we have at the regional level for 2022 and 2023, as I mentioned in my opening remarks, we had 17 countries that reported over 284,000 cases and over 5,000 deaths, with a case fatality rate of 1.8. If you disaggregate this data further, you will realize that we have actually high case fatality rates among communities compared with hospitals. Some of the countries have reported over 3% CFR. And as I said at the beginning, the CFR should never go beyond 1% if we are doing things the right way. And therefore, cholera remains a major challenge in our region. And there are factors that would call them complicating factors. We all know that issues of climate change has really affected us, from drought to floods. All this contribute to the spread of cholera, natural disasters, including cyclones that come and damage our infrastructures. We have some of our countries like Mozambique and neighboring countries that have been hit by cyclones. And that again comes with the destruction of the water systems, sanitation system, and therefore it can be a precursor to cholera outbreak. We also know within our region, a lot of conflict that is going on with the displacement of populations, which disrupts the access to healthcare and sanitation. And in several countries, you'll find our health systems are being overwhelmed, coupled with inadequate wash conditions that hinder effective response. Many countries are battling multiple outbreaks, and therefore with concurrent outbreaks, you'll find that the resources get strained, and also it complicates the whole public health response effort. Let's go to the next slide. We have some ongoing initiatives in the African region, and these are supposed to help us to combat cholera outbreaks. And some of these initiatives include ensuring that we use a multi-sectoral response approach in cholera preparedness and response plan. And most of the countries have been able now to move in that direction. Appreciating the fact that while cholera is dumped at the doorsteps of ministries of health, but actually in most cases, the problem is emanating from the water sector. So we need a multi-sectoral approach. We also know that population mobility has a great influence in transmission and spread of outbreaks. And therefore, we have cross-border coordination efforts going on, ensuring also oral cholera vaccination campaigns are done where we are supposed to do them, but these should not replace the critical issues like WASH. Surveillance, forecasting, very, very important tools that are now available with us, and also ensuring that we have provision of essential medical supplies, including the cholera kits. We need to ensure also that we do water quality testing and WASH intervention, and these tools are available to ensure that we are able to map some of those hot spots, because we are doing continuous surveillance, including looking at the quality of water. The risk communication and community engagement is at the center. We all know that outbreaks begin and end in communities. For us to succeed, communities must be at the center of our interventions. Many of these initiatives align very well with the Early Action Review and the 717 principle by focusing on IHR core capacities needed for preparedness, early detection, and rapid response. And I'm certain that these terminologies, they are conversant with many of us. When we talk about preparedness, we should ensure that we have plans that are developed, and we have prepositioned supplies, and we do readiness assessments and trainings to ensure that we are ready. We are seeing countries that are doing these activities in good time. They are better placed in handling the outbreaks. Early detection, ensuring that surveillance is enhanced, active case finding, and also using forecasting tools. We are now having tools that are AI-based, and they are very good in forecasting outbreaks. And we have used some of them in our African region for cholera forecasting in some of the countries. Rapid response, ensuring that there are no delays in vaccination campaigns. Case management is done well, because if we do case management in good time, then we are going to reduce the case fatality rate. And also ensuring that we have WASH interventions. Next slide, please. So, strengthening preparedness, we need an evidence-based approach. And one of the things we have been asking ourselves in African region is that the preparedness interventions that we are putting in place, are they bearing fruit? If you look at this figure that has been provided on the right side, the first one, you'll see the bar. It may not be very clear, but is comparing all the WHO regions, and the tallest bar, that is Africa, that is doing so many activities around action reviews, early action review, interaction review, after action review, simulation exercises. And when we looked at the activities, we had done 484 activities between 2016 and 2023 in our 47 countries. Then the question is, with that tall bar in Africa of so many accomplished activities, are we having any impact? The good news is that through our analysis, we have seen that countries that completed most of the intended activities, they reported faster times for detection, notification, and response. And that is encouraging to see that these activities, they are not just being done and we celebrate we have achieved so many, but we are able to measure whether they have some impact. So this is the direction to move, whereby we are able to be guided by evidence. And therefore, this is the focus we are looking at now, collaborating with our colleagues in HQ, working with also our partner, Resolve to Save Life, and many other partners. We are moving in this direction whereby we want countries to ensure they implement preparedness activities and be able to measure the impact or the outcome of those activities. Let's look at the next slide, please. Okay. I hand over back to you, Robert. Thank you.
Thank you, Charles. Thank you, Dr. Charles. Just before we move to the next session, just to remind participants to continue to use the Q&A section to ask questions pertaining to the presentations, and we'll come to them towards the end of the webinar. Also, as participants, some of you are already doing, you can use the chat function to introduce yourself and the country where you come from. Thank you. I now really call now upon Dr. Nimo Kando, the Unit Head for Risk Analytics and Action Reviews Unit, to come and give his remarks and also present the project overviews and alignment with WHO goals. Dr. Kando, please.
Thank you, Robert, and good morning, good afternoon, good probably not good evening, because we are more or less in the same time zone. As opening remarks, I don't have to say anything. Charles already covered nicely. Just to thank our Afro colleagues, all the participants, our team here, and the Save Life team who supported on this project. Can we move to the next one? I just want to build upon what Charles said earlier. We did a lot of activities, and still we have a number of outbreaks there. And I think it brings to one, it's not a story, it's a real event. Like last year, one of the head of states of African region asked, we are investing a lot on preparedness, but we are still seeing the cholera outbreak. So where is the fault? What is the challenges? And this is where we started looking at, we need to look at not only the process and inputs, we need to look at the outcome and impact also. And I think this is an excellent opportunity to go through this outcome and impacts level analysis. And this is where this project is quite important. When we're conceptualizing this project, we wanted to look number of events, but as cholera outbreak is going on, and Charles mentioned 17 countries having those outbreaks, and cholera is quite common disease. Let's look at the cholera timeliness, and we build upon on this one. So this project will look at the timeliness of cholera response, and we are aiming to identify what's going well and what's not in order to improve our preparedness, readiness, and response capacities, or rather I call capabilities. And we did this decision also based on some analysis, because it needs to be data-driven or evidence-based. So if you can, we will share the slide also, but if you can see, the affected countries in red color has shown recent increases in diarrheal disease burden compared to unaffected countries. Right. And affected countries have a slow detect, notification, and response times reported compared to reported to WHO since 2018. And also affected countries that higher score. Here, higher means the highest risk of diarrheal disease as per our dynamic preparedness metrics. So the project is an extension of initial analysis. We further wants to dig where are the bottlenecks based on the DNR, stands for the detect and response indicator, which is timeliness specific to cholera outbreaks in African region. So we use the data from 2022 and 2023. And Charles already talked about early action review methodology. My colleague Enrico is going to talk more about that to determine enabling factors and bottlenecks in response to these events. And analyzing findings to determine what factors, that's key factors for preparedness as well as readiness, that can improve faster time detection, response, and in turn lead to the fewer cases and deaths, which are our outcome and impact measured also. So if we detect early, patients are in hospitals, early recovery, so less case fatality rate also. And if our surveillance system is sensitive, we have early warning, and then we prevent cases as well. Next slide, please. So what is our goal? Our goal is to generate evidence that was based on insight to strengthen cholera preparedness, but lessons learned from this cholera can be applicable to other threats also, not only cholera, and also helps on integrating overall goal of the IHR monitoring evaluation framework and other global tools. The key objective here is to analyze timeliness factors, identify best practices and lessons learned, and to develop some actionable recommendations also. Probably you all are aware that the IHR WHO benchmarks has, in the portal, we have the cholera actions also, which countries are using in order for preparing and being ready for the cholera events. And we would like to see the impact, not only how many protected people as per GPW 13 and 14, but we want to see overall the reduction in the burden of cholera in terms of dialysis, and also in terms of economics, as well as to ensure the global health security. And this is one of the key project which not only can be applied for African region, but for other regions also. So whatever it comes out, we will be sharing with other regions in order to put some related and relevant context-oriented activities over there as well. Next slide. So this is an opportunity where how we can address those bottlenecks, what are those best practices, and that can be used to demonstrate more impact, and it can contribute to the global monitoring and learning also. Probably you are aware of health emergency architecture, but this is based on all the review committee's recommendations, various panels for the COVID pandemic. WHO has developed the health emergency architecture on different pillars, which we call 5 Cs. I'm not going to in details, but at the same time, we also have IHR amendments, which has highlighted the importance of the early detection, response, and notification also. So with all this in place, what we want to see is to more people are protected from the event like cholera and others, because the cholera we are using as a use case, but this will apply to, as I mentioned, to other biological hazards as well. And one of the key element of the measuring impact that we've been promoting and using is the number of people protected. And this comes from one of the thing is this: when the country improves their 717 timeliness metrics, that means improve early detection, early notification, and timely response, that will increase the number of people protected from the health emergencies. So with that note, I hand over back to our colleague, Robert. Thank you.
Thank you, Nimo. And now I want to call Landry and Rico to take us through the overview of the early action reviews and the 717 targets. Landry, you have the floor.
Yes, good afternoon, colleagues. If we are to avoid the fallout of another global pandemic, we need to be better prepared. There is evidence out there that early interventions or early actions can reduce outbreaks impact by over 50%. You can find this, it's published, it's all over the place. But I would use just one example of dengue in China in 2015, when they used really early actions to reduce the outbreak impact. Early action review aims to make sure that a small outbreak does not go out of control. A small outbreak does not lead to a global pandemic like we had for the COVID-19 pandemic. And how can that happen? It's only if we have capabilities at country level, at community level for early detection. As soon as we detect, as soon as we notify, and as soon as we trigger the response and control that outbreak from the onset, there is a huge chance that that outbreak will not, go beyond that locality and touch other countries and finally end up in the pandemic. Next slide, please. So why early action review? So I would like to put the 717 into perspective here and how it fits into our, what we call the health emergency management continuum. As you can see on this slide, it all starts with a simulation exercise. Why do we do simulation exercise? We do simulation exercise to shape our health security planning, but also to test and validate our functional capabilities. Capabilities, it's more about how do our capacities functions, how do they perform? Having a laboratory is one thing, but having a laboratory that works, that is able to deliver, that is able to provide a result in time is another thing. So the simulation exercise can really help us to test that, through a simulated scenario. But when the outbreak hits, we have the opportunity now to test our capacities or our capabilities through a real event. And early action review comes here now to make sure that that early phase of the response is really managed well so that that small outbreak does not go out of control, as I just said. And 717 is the bedrock of the early action review. And then I will come back to that. And then when the outbreak continues, for the sake of course correction, for the sake of making sure that we are on the right path, an interaction review can be conducted. The interaction review methodology started with the COVID-19 pandemic, but now it has evolved. And I would like here again to thank Dr. Charles, who just talked about Africa, or Afro being the region that has implemented most of those assessments. Afro also started doing interaction review for cholera, for measles, even for for humanitarian crisis, like in Madagascar for the food crisis that they went through. And what this is for when the outbreak is becoming, or the emergency is becoming protracted, and we want to make sure that we minimize what we call the recall bias, because the quality on those reviews relies on the quality of the information that we are collecting in terms of the challenges, the bottlenecks, and also the best practices that, the underlying factors enabling those factors or those bottlenecks. If we can remember those details, it helps us to be able to propose course corrections that can help to improve. And then when the outbreak or the emergency is declared over, we have the opportunity to do an after action review. And this one, we propose to do it within 3 months after the outbreak or the emergency is declared over. Again, as I said, to make sure that we don't forget those details, because we need them to be able to plan better for the future. So out of those assessment, those functional assessment, simulation exercises, early action review, interaction review, and after action reviews, we have 2 different types of recommendations. Very soon you'll start hearing it. We started it 6 months ago using the concept of CAPA, corrective actions, preventive actions. Because some of the actions, they're really to make sure that we solve problem, but it's important also to think about the actions that can help us to prevent those problems from happening again. And in most cases, the two interventions are different. So it's always good to think about the approach of CAPAs when we are proposing those recommendations. Some of them can be for immediate actions and do not require a lot of resources. And some of them can be more for long-term action, long-term planning and require a lot of resources. And they're the ones that can go into our National Action Plan for Health Security. So next. So here, the early action reviews guidance was published in August 2023. And as I said, we are using the 717 as the bedrock. And as part of this guidance, we have also a toolkit accompanying it. And the most important one is the early action assessment tool, which I'd like to encourage you. If you scan this, the code, the bar, not the barcode. If you scan, how do you call this again, Cynthia?
QR code.
The QR code. Thank you so much. So if you scan this QR code, or you can even Google guidance for early action review, at the bottom, you will see a set of tools that we are proposing. And one of them is the early action review tool, which really takes you through on what to do and the different steps to consider when collecting the 717 information. The first one is to record the dates of milestones, you know, the day of notification, the day when the samples were collected and the lab results were released. And then the step 2 is to calculate the timeliness in 717 intervals. So here it's more about computing for each, I'm talking about the 3, detection, how much time it took for detection. So you will use the data that you will have collected in the first step to be able to compute that. And then you will calculate also the time to notification and also the time when the initial actions that I will show you now will be initiated. And then the third step is now to identify the key bottlenecks, because it's very important, especially when you have delays in terms of before detection or delays before notification or delays before the response was triggered. Why? And here we are encouraging you to go a little bit deeper and identify what you call the underlying factors or the root causes behind those delays. And that's what we call the bottlenecks, really to understand them so that you can propose what we call the corrective actions or preventive actions. And also, of course, as I said, some of them can be for immediate actions and others can be for more long-term implementation. So again, as I said, to finish this slide, it's all about preventing a small outbreak to grow into a global pandemic and to be able to strengthen our capabilities to detect as fast as possible. Next, please. So those are the, again, please. So this is, you will hear a lot this during this presentation. So the first 7 is about time to detection. Time to detection. So here we're talking about the period, how much of time it took for the country or for the outbreak to be detected, and how much time it took before the notification, and how much time it took to initiate the early response. So, and then based off the time that you will be receiving, you'll be getting from those, from doing those calculations, then you will be able to identify if there is any bottlenecks, especially when there are delays. Next, please. So those are the 7 response actions that we are proposing to be initiated within the 7 days after the official notification of the outbreak. So the first one is to make sure that the investigation has been triggered, to make sure that we have a proper understanding in terms of the burden of disease, and also the initial risk assessment has been conducted, to make sure that the laboratory confirmation, you know, in terms of etiology of the outbreak has been determined, make sure that we have appropriate case management and IPC measures in place, to make sure that we have the public health countermeasures also implemented, and of course, risk risk communication, community engagement activities, but also we have established a coordination to respond to the outbreak. So those are the 7 activities that we are proposing to be initiated. And of course, you will tell me that maybe some of them may not be initiated within that 7 period, but at least one of them, or most of them, if they're initiated, it gives a good indication that you're really on track. So let me stop there by just, Amarachi, can you just confirm that I don't have another slide after this? All right, yeah, this one is very important, yeah. So again, as I said, the key steps for using the 717 target under the early action review start with collecting the timeliness data, as I said. This one, you do it as soon as the outbreak is declared or you have suspicion of the outbreak. It's good. You start observing, all the key milestones in terms of detection, in terms of that, and this information need to be, need to be documented, and then calculate the 717 intervals, as I said, identify the bottlenecks and enablers. Enablers is when you have the things that are working or the good practices that you've identified. It's good also to perform the root cause analysis to understand why those best practices or good practices are happening. And then I talked about identifying or proposing the corrective actions, preventive actions, and then also make sure that you routinely consolidate this data and monitor the progress of actions, because it's very important to make recommendations, but to follow through, to follow up on them, it's also very important. And also, of course, you can use the findings like Nirmal said, for planning, financing, and advocacy purposes. Next, please. So those are some of the key publications that we've put out there. There's a podcast that we did with Dr. Stella, our director, that I encourage you also to, you can find it also through Google, but you can use the QR code to access it. And also there's some other promoting material of the early action review methodology that you can find there. Just to finish my presentation, I would like again to emphasize on 2 things. Early action review is not about the numbers. It's not about the 717 and the delays and how we performed against those numbers. It goes beyond numbers. And that's why we keep encouraging countries, because if we stick to numbers, we can miss the point of what we're trying to achieve. It's more about performance improvement and continuous learning by really looking critically at those bottlenecks that we have identified against those numbers and being able to see our areas where we can improve in our response capabilities, in our detection capabilities, in also in our notification capabilities. So I encourage you, of course, to read the few publications that we have shared there. But I understand also AFRO is planning to do more trainings. I've been discussing with Alan a few days ago, and they're thinking about rolling out some more trainings on 717 and early action review, and we look forward to working with you. Thank you for your time and for your attention. Over.
Thank you, Lantry. And now let me call upon Dr. Cynthia Bell to present now the project objectives, as well as the expected outcomes and methodology. Over to you, Cynthia.
Thank you, Robert, and thanks to all the panelists. We're very happy to see so many people in attendance today and interested in this initiative. And it's my pleasure to introduce the project objectives, methodologies, and expected outcomes. Next slide, please. As we've discussed, the 717 framework provides a crucial target for timely emergency response. And we define these 717 times based on 4 important dates. The time from date of emergence to date of detection defines the time to detection. The time from date of detection to date of notification defines that time to notification. And then lastly, the time from the date of notification to the date of early response completion defines the time to early response. This project focused on translating these 717 goals into effective action on the ground that will ultimately result in better outcomes for people. Our goal is to focus on understanding the challenges and opportunities in achieving these targets and learn from recent cholera outbreaks in the Africa region how we can improve for all outbreaks around the world. Next slide, please. This project has three main goals. The first of which is to define how can 717 data be used across existing work streams and tools. And this includes the early action reviews, which we've gone over, the IHR monitoring and evaluation framework, strategic preparedness, readiness, and response plans, situation reports and bulletins, and many others. The second goal is to determine what is the impact of achieving 717 targets on health outcomes in terms of reduced cases, incidents, limiting the geographic spread of an outbreak, reduced case fatality rate, as well as overall burden of disease. And then lastly, we aim to determine what are the key capacity building needs for countries to achieve these 717 targets. And these can be thought of in the areas of community protection, emergency coordination, collaborative surveillance, access to countermeasures, safe and scalable care, and also taking into account the vulnerabilities and threats at a national and subnational level that enable or hinder these kind of responses. Next slide, please. We plan to meet these goals with a study design that employs a retrospective observational approach using country-level data to analyze the relationship between 717 implementation and health outcomes. The expected outcomes from this project will generate evidence to support wider adoption of 717 targets and inform the development of more effective interventions for health emergencies. This will be done through generating evidence on what preparedness capacity building efforts most impact the ability for faster detection, notification, and response, and then ultimately demonstrate that meeting the 717 goals will reduce outbreak number, size, and mortality from communicable diseases. The key deliverables at the end of this project will be a policy brief and a publication draft that summarizes the results and provides actionable recommendations for how to strengthen 717 implementation. Next slide, please. Beyond the direct project expected outcomes, we aim for participation in this project to promote better partnerships for emergency preparedness, readiness, and response. And we see the benefits of participation to include learning from a review of a country's response efforts with assistance from early action review specialists, sharing lessons for all in the region and world to learn from, fostering a collaborative regional network of stakeholders committed to improving cholera response, and publication and policy brief input on what tools are useful and preparedness strategies should be prioritized, with participants' acknowledgement in all publications. With this, I thank you and pass to the next section to provide more details on survey tools, a data collection process, and the opportunities for participation. Thank you.
Thank you, Cynthia. And now we turn it over to Fred Kapaya, who will talk about the details regarding data collection and the survey details. Over to you, Fred.
Thank you very much, and thank you, Cynthia, and all the other presenters that have done great work before me. So my role is to take you through how we are going to actually conduct this survey in the African region. First and foremost, I just want to bring to your attention that our goals mainly will be to enhance stakeholder understanding of the objectives and methodology of the survey that we are going to undertake. We're going to administer a survey and also in-depth interviews to facilitate the data collection that we want to have for this project. and then also foster a network of stakeholders that are committed to sharing best practices and experiences in cholera response. So, what methodology are we going to use? I want to indicate that we are going to have a two-phase data collection approach. I really want the countries in attendance to really understand this, because this is the gist of what we are going to do as a project. So we have a phase 1 and we have a phase 2. So in phase 1, we are going to share with you an online structured questionnaire. This questionnaire is going to help us collect key dates for the 717 timeliness matrix. Here, we will collect data on detection, notification, and response. Then we have a phase 2. In the phase 2 will follow the phase 1, where we are going to have an interaction in form of interviews, focus group discussions of the key stakeholders. And in this phase 2, we want to understand the enablers. What made you do certain things that you did that resulted in the success of the response to the cholera outbreak? Then also the bottlenecks. What challenges did you face? What made you fail to do certain things that you were supposed to do? Why was your case fatality rate very high? And then from there, recommendations to improve future response. So on the right here, you can see the map of Africa, and those countries, the 17 of them, are the target countries for this project that we intend to undertake. Next slide. What are the data sources? So the possible data sources for the 717 will of course be the national MOH cholera outbreak reports, surveillance systems, which may include the CTREPs, line list, incident action plans, interaction reviews, after action review reports, of course, HMIS, DHIS2. All these are some of the sources where we can get the data that we need. Also, our country offices, WHO country office reports, reports from other international organizations like UNICEF, our local NGOs, and also from the community health reports and the facilities. So you need to actually cast your net very wide and collect as much information as possible that we need to be able to answer the 717. The next question is, who should participate in this project or in this survey? Number one, we are saying all country cholera focal points or people that coordinate the cholera control activities in the country, from the ministries of health, from national public health institutes. These are very key. The other group of people that we are looking at is the incident management teams, the incident managers, that is, people that were responsible in responding to the outbreak that occurred between 2022 to 2023 in their respective countries. Now, we are not saying you bring everyone, but at least if you can have the pillar leads, the people that were leading the specific pillars of that response. Then, of course, we also need to bring in national and subnational officers whom we think are key and were involved in the outbreak response in 2022 to 2023. Then key line ministries, including ministries that are responsible for water, sanitation, environment, and any other that you think are very key. And then, of course, WHO country staff, the key partners, including UNICEF, IFRC, Africa CDC, WaterAid, any that you think is very key and was involved in the cholera outbreak response and surveillance in the period under consideration. Next slide. So how are we going to carry out the phase 1 and the phase 2? So the first thing that, first of all, each and every country is required to do is to actually nominate or select or choose a focal person or coordinator that is going to coordinate the 717 project. So I emphasize, each and every country should choose or select a focal person or coordinator that is going to coordinate this project up to conclusion. Then we'll ask that the selected person, you share the contact details of all those people that you have chosen per country. You share the details with the WHO country office and ourselves as the WHO project team. And we are saying, if you could share this by this Friday, March 7, 2025, we need to know of the 17 countries, the project coordinators for this project that we are doing. So in phase one, what is going to happen is that we are going to bring together all key participants in one place, and then we fill out the online questionnaire together. We bring together all key participants. So this is again the work of the project coordinator that we are going to choose per country. And then we bring all these people together and we fill out the questionnaire. In phase two, we are going to bring together the same participants that have participated in phase one for an in-depth interview with the project team. So we are going to interact with you online, but you'll be in one area, and then we'll actually be able to have in-depth interviews. Then also a comment on stakeholder engagement and data quality. So we are asking that each country should identify all key stakeholders that participated in the response. Then they need to convene a meeting before filling out the survey questionnaire, as well as before doing the in-depth interviews. So this is where you give them a briefing of what is expected. Then we also are asking that we need to gather all the necessary cholera outbreak reports that we can use when we are filling out these questionnaires as well as the interviews. What are the timelines? So in phase one, what we are going to do after you have shared the names and contact details of the project coordinators, we are going to have a briefing, a detailed briefing of the 717 of these focal persons, together with at least one from the WHO country office on Tuesday, March 11, 2025. That is next week. We're going to have this detailed briefing of the focal persons. Then after this briefing, we are going to share the online questionnaire with the focal persons. And then after that, we'll task the focal persons to coordinate the filling out of this questionnaire, and we are giving a deadline for submission of a fully filled out questionnaire of March 18, 2025. So we are saying that by March 18, 2025, we'll have received filled out questionnaires from all the 17 countries. After that, we'll then move to phase two, where we'll conduct the interviews, which will be 1 to 3 months after phase one. These interviews per country will actually follow the order of the responses, meaning we are saying first come, first serve. So the first country that will submit the online questionnaire will be the first country that we are going to actually interview. So in a nutshell, this is how this project is going to be conducted. Thank you very much, and back to you, Mr. Moderator.
Thank you so much indeed, Fred. And right now, I want to call upon Peter Mala to take you through the expected impact of the project, its global context, and the next steps. After Peter is done, we will directly hand over to my co-moderator, Alan, who will take us through the Q&A session. Thank you very much, and over to you, Peter.
Thank you. Thank you so much, Robert and colleagues. Mine is just to emphasize, after all the wonderful presentations we've had, is that at the end of the day, what we want to achieve in all our efforts in disease outbreaks is reduction in morbidity and mortality. And with epidemic-prone diseases like cholera, timely detection and timely response is the key. If we can beat the disease to the bend, get there ahead of it, and put our interventions in place in a timely manner, we can significantly reduce morbidity and mortality. And this is what 717 is trying to emphasize. And hopefully through the presentations we've had that are sunk in. So again, we'll just emphasize that as we move forward, let's all engage, make sure the survey is completed and we learn the best lessons we can learn about 717 in practice. And I believe that the lessons we're going to learn from this project will translate to other epidemic-prone diseases. So let's take this opportunity to get the best data we can. Let's make every effort to put together the country teams, and let's all be motivated, because the impact will go beyond cholera, because the lessons we learn from here could have very broad ramifications that will help with a lot of other epidemic-prone diseases. The list is long. You know them all. So thank you, and back to you, Robert.
Thanks. Over to you, Alan, for the Q&A. Thank you so much, Peter.
Thank you very much, colleagues, and thank you for those very informative discussions. So there's an option for those who want to voice their questions live. Please, you can raise your hands, and then I'll work with Amarachi to give you access to the microphone. But we do have some questions in the Q&A session. Some have been responded to. So I will go straight to those that have not been responded to, and I will throw the questions to one or two of the facilitators, the panelists, and if they're able to answer them, fine. If not, they can always advise us on how to. So there's one question, and David Simawa, this must be from Zambia. He says, how can the member states ensure compliance, in brackets validity, in the collecting, documenting, and use of time-related variables to compute the 717 targets within the context of IBSR? Are there any practical sessions? Maybe Dr. Landry will take that. Elizabeth Mzioka is asking, how can this metric be applied for public health threats other than disease outbreaks? What will be the measure? I'll also give this to Dr. Enrico. How long is the project? I think Dr. Bell, Cecilia will take this. We have a question on cholera. They're asking, what is the vaccine efficiency? What is the vaccine efficacy of OCV? I think this will be Dr. Kapaya. And then another one is on the lab. Someone is wondering, the lab confirmation, is it in the first part of 717 or in the last part, detect 717? Dr. Enrico can also take that. Let me see the hands. I'm not able to see any of the hands up. Maybe we first take that as I mobilize the second round of questions. Over to you.
What is the last question?
And then the last question was the lab confirmation. Where do we place it in terms of the timeline?
Okay.
Is it in the first 7 or in the last 7?
And I can also chip on it.
Okay, fine. Okay,
So,
over to you. Then we.
Yeah, definitely. Everyone online, especially and including Dr. Charles, please feel free, because I'm not I don't have the mandate to talk about IDSR. I'm going just to voice my opinion, if you don't mind. Actually, we in our last webinar that we had recently, there was of course a huge question on how the 717 aligns with IDSR when it comes to detection, notification, and response. So the quick answer is that they don't contradict each other. 717 is just focusing on a specific, on the specific 3 target, which are detection, notification, and response. Looking at the target, and then looking at it, and then and seeing if we have accused any delay, and be able to provide any course corrective actions moving forward. So it's not really contradicting IDSR. And then we had cases. I was discussing even yesterday. I mentioned this to Cynthia. With one country, and the detection, they took like 46 days to detect. I don't want to mention the name of the country. And then the minister, afterwards, we did a member state briefing with Global Fund about early action review and 717. So I don't know how the minister was informed about that number of 46, and she didn't seem to be happy about it. And then she voiced her opinion, saying that she doesn't agree with that. And then so we need to be also very careful whatever number we are proposing, to make sure that it's an official number, it's an official date. And that's why the earlier we compute, the earlier we document those data, it becomes easier when we're trying to fill in the 717 target. Otherwise, when people start speculating, it's like, oh, it happened 6 months ago, nobody's remembering those dates. It's always good to make sure that we go through a proper validation and verification process within the competent authorities, within the Ministry of Health, to make sure that whatever number you propose is really the official number, so that we don't end up in a very controversial situation and all that. So that's the only thing I can say. IDSR and 717, they align. One is just focusing on detection, notification, and response, but IDSR really goes beyond that. The second question about other outbreaks, yes, now we are talking about cholera, but the 717 really, goes beyond that and applies to other communicable diseases. However, there's still some discussions, especially for zoonotic diseases, because zoonotic disease, when it comes to detection, it can be very tricky and all that. And sometimes, or in most cases, to be very hard to meet that 7 days target for the first 7. That's why it's very important to not stick to the number, but to really stick to the discussions that the number, can elicit, can provoke after you've computed the first 7. So yes, it applies to other infectious diseases. You can use the 717 target. So the lab confirmation, yes, it applies for detection, because that's where, after you have the lab confirmation, then you really can have more visibility on the outbreak that has been detected. Of course, there have been some discussion. What about what happens in the symptomatic surveillance, syndromic surveillance, and all of that? But the lab comes really to confirm about the outbreak. So it really applies to the first 7. But as you can see also in the last 7, we are talking about the key response actions. We are now talking about the etiology, of the outbreak, which disease, which virus, or which pathogenic agent we are referring to. So I would answer that laboratory confirmation comes within the first 7. Over and back to you, maybe Dr. Charles, for any kind complement.
Okay, can we have a response from Dr. Bell, and then Dr. Peter will come in.
Yes, thank you. It's a really important question, and really gets to a lot of the reasons why this kind of study is important, to look at the real world, use of the early action reviews and 717 targets, and the detailed questions on how to define these times to detection, notification, and response, because they are nuanced and they do vary by each event in each location. And again, getting to what Enrico was saying, you know, that the dates and the times are only one aspect. The follow-up and understanding the nuances and the situations involved in each of those timeframes is important. I'm not going to go into more detail on that aspect. I think my question was more about the project length. So the total project length is throughout the entire year of 2025. But as Dr. Kapaya pointed out, the beginning part that we are asking for your participation in is currently in the next week to few months. So by this Friday, we are asking for focal points to be identified and communicated to the WHO country offices or to us. And then next week, we will then meet with those focal points to review the survey tools in detail and talk about more of these same questions about how to define dates and IDSR and data sources, and how to review those tools. And then we ask for that form to be filled out, the first phase, within a week. And then after that, we will then follow up over the next 1 to 2 months with the focal points and the team of experts that they've gathered to do a short interview about the specific events to get those details. And so this should all happen, we hope, before May, the interviews, and then that will give us time to compile all the results and then come back and present and share those results with all of you. I hope that answers the question. Thanks.
Thank you very much. Dr. Peter, you wanted to come in?
Yes, I wanted to clarify, though my colleague Enrico has mentioned it, but let me say this from a surveillance perspective, because I have a long background in surveillance, early warning systems, and so on. So when 717 first appeared, I was a little bit skeptical about it, but over time I've seen its value, and I've been a strong advocate in HQ that the surveillance unit, because I'm no longer there, my colleagues in surveillance take it on and develop the right SOPs for it. And understand in Afro, actually, you're way ahead of HQ, understand it sits with IDSR. So let me break it down like this. The first 7, in the past, we didn't bother with it because, as Enrico mentioned, depending on the disease, from the time the disease appears until somebody detects it in the hospital or in the lab, sometimes you would not know, depending on the disease, as my colleague has already mentioned. But for those that we can, that 7 is a reasonable figure to work with. That's the time from whenever the disease occurred, and that will be from history of the patient to the time they get to the hospital. Now, the 1 day that we've always had, if you go to any IDSR or any early warning document, they'll say an epidemic-prone disease should be reported immediately, and that immediately has always been defined as within 24 hours, which is 1 day. So the 1 is okay. That has always been there. Now the 7 is new, but it is reasonable. And this 7, and this way I think I want to break it into two for you, because now 717 is being developed from the preparedness and response side of things. So it lumps 2 things. That 7 combines 2 things. That R combines 2 things, and that's what I thought I should break down, and probably it will help. It combines what we call the epidemic intelligence part, which is verification, investigation, and confirmation. Then it also has the second component, and that is the implementation of control measures, which is the actual response. So somebody will notify either from the lab, depending on the disease, or syndromic from the hospital. Once they notify, The surveillance team will initiate verification. That's the first part of response. They'll verify, they'll send a team to investigate, and they'll collect samples to confirm. So that's why maybe to avoid confusion, confirmation to a large extent happen with the second 7. That's when samples are collected, brought, and tested. But for some special diseases where detection depends on the lab, yes, then the 7 will be over there. But for most diseases, confirmation happens with the second 7. When you verify, collect samples, take it to the lab, and so on. Then there is the deployment of control measures. So I just wanted to make it clear that the second 7 has 2 components: the traditional surveillance bit and the actual response. And maybe this is why I've been advocating that in HQs, they need to take it on and come up with proper SOPs that bring this out. Right now, that's not clear, but I hope AFPRO, since it sits with IDSR, you'll be trailblazers and iron this out and bring out SOPs that will help everybody. So thank you.
Thank you for that. Dr. Kapaya, there was a question on the efficacy, and then I will go online. There's some questions online.
Thank you very much. Yeah, so of course, just to indicate that OCV is one of those measures that we employ in trying to control cholera for prevention, as well as to halt the transmission. So usually you can give it as a single dose for reactive campaigns when you have an outbreak. You can also give it as a preventive measure where you give 2 doses. But all in all, if we talk about the 2 measures, the efficacy within the first 1 year is about 56, 57%, and then effectiveness is about somewhere above 80%, 83%. So that's where actually those are the values that you need to look at. So in the first 1 year, it's quite, the protection is quite high, and then it starts waning down as you move after the first year. Thank you.
Okay, thank you very much. We do have 2 hands up. There is Warrior. Maybe. Can we begin with Warrior?
Sorry, Alan, you're breaking up a bit. We can't hear you.
Okay, I was saying we have 2. Can you hear me now?
Better now, yes.
Okay, I was saying we have 2 colleagues online who have their hands up. One is Warrior, and the other is Mwinyi. So let's begin with Gumato. Please open your mic and let us know what your question or concern is. Okay, Mwinyi, please go ahead. Your mics are open. We cannot hear you. All right. As we sort out possibly as the IT. So Christopher, can you please ask your question, Christopher?
Yes.
Kamal? Yes. Please go ahead.
Yes, thank you so much. I hope I can be heard. Mine is just to support the call by Peter Amondi that an SOP will have to be developed on this 717 and serious capacity building given to member states, because as it appears now, there seems to be a whole lot of confusion of specific metrics indicators to measure from this approach, especially with the first 7. So I think if an SOP is developed and member states trained, it will help. The second part of my question is on platforms. I know for Afro they have the EMS where the store most of this information regarding outbreaks and the like. So for member states, where can they actually capture this information such that at any time when they will need to have an intra-action review, after action review, or even early action reviews, they can reliably rely on them to be able to facilitate recall and others. So I think that is what I have for now. Thank you, and over.
All right, thank you. One of our facilitators will pick up that. Let's say one more. Mato, Mario, please ask a question.
Dr. Alan, you're really breaking up. We cannot hear you.
Okay, now let's call on the oblique. Mato, Warrior. I don't know if he or she can hear us. Okay. Let's. Does any of the facilitators want to take the questions regarding the platform? Our colleague was asking if there are particular platforms that that we can have. I know different countries and different agencies have different platforms where they store their data and display their data.
I can come in there.
Okay.
Alan, there is a platform which we call event management system that WHO country offices submit to WHO based on the report available from the Ministry of Health. It is there for a long period. And probably you all know that this is outbreak news that you have seen in a WHO website. And also, if you are IHR focal point, you might have access to EIS, event information site. So event management is more internal, and once submitted, Ministry of Health submit the notification of the disease event, and that is more or less for the those potential Annex 2 of the IHR event. And then the country office usually submit that, and then the EMS moves to the EIS, which is more open to the IHR focal point, not to the public. But some verified event, they go to the disease outbreak news as well. But that's quite established time as part of the IHR, and it's there. But and whatever the DNR metrics that detect and response indicator that we talked about earlier, the data that we generated from 2018-19 is from those, but they don't capture all events. So there are a lot of gaps on notification, and it depends on the region and countries on this one. But however, having said that, this is why 717 is going to play a vital role even to improve this notification, and we have the metrics there available so that we can demonstrate that over the period of time the detect and response capacity improved. That means the surveillance capabilities has improved, and that come as an outcome. So sometimes, to make things simple, what I used to say as part of our GPW, Global Program of Work 3 indicators for the protected population. From health emergencies, we have a prevention, we have the preparedness, and we have the detect and response. So what I used to say is when the country has a well-prepared function or capabilities in place, the country would be able to prevent also. And as an output or outcome, we have the improved detect and response capabilities as well. So currently, we rely on the existing platform, but gradually, as Peter mentioned, it's one of the area which we've been talking to, even with the FETP, Field Epidemiology Training course. It should be embedded in the curriculum as well as moving forward, because timeliness metric, not only 717, the timeliness metrics that WHO published in first after action review guideline in 2016-17. I think we have that timeliness metrics from the beginning. all the events. So I think I'll stop here. The platform is there, but it needs to rework. We need to improve it, and once we have the better knowledge, more awareness at the country level, at all levels, and we'll have the information coming in, and that platform will definitely help. Charles, do you want to add on on these things? You are one of the lead pioneer also when we all were in a country office when using those EMS and these things. Over to you.
Thank you, Nema. Let me first go to the issue that was raised earlier about the issue of IDSR and this 717, and remind us that IDSR is a strategy that began in 1998 in the African continent. And we have 3 editions that have been rolled out all over in Africa. The 717 matrix is something that is more recent, and it helps to measure the timeliness because also IDSR has indicators. And there was a webinar on the same, looking at or comparing the IDSR and 717. The first 7, the issue is about the components that are included in each. And you'll find that they agree and there is commonality. The easiest one is the 1, which it's very clear. The second 7, which is the last one, that is whereby the components in terms of definition, you may have some challenges. And that's why it needs to be made very, very clear to countries so that it doesn't bring any confusion. I do agree that there is a need to have a guiding document, whether you call it an SOP or whatever, but there is need for a guidance document that will be able to help countries to better understand about the IDSR and how the 717 is complementing the IDSR. So that is something that has been discussed at the regional level, and I believe the program area will, a manager in charge will be able to take it forward in terms of ensuring there is clarity in countries. I do understand that it is not very, very clear, and there is need for clarity. Otherwise, generally the 2, they complement, there is complementarity aspect, but we need to dive to the details in terms of defining some of the terminologies and those components so that things are clear. Over to you. That's what I wanted to add.
Thank you very much. Thank you very much. I think there are some more questions. And I see one more hand. Let's first take the hand. Our colleague Yahaya, if you can please ask your question. Please be brief. We have 10 minutes to close. And there are a lot of questions in the Q&A.
Okay.
Yahaya, can you hear me?
Yeah. Yes, I can hear you. Thank you for yielding the floor to me. I would like to sincerely appreciate the team for organizing this session. So I'm Yahaya Apreki Kono, and I'm the 717 consultant, National 717 consultant from Nigeria. And thankfully, we are part of the teams that started piloting 717 globally. So I just wanted to just quickly state that it's understandable that at the very beginning, there might be some kind of gray areas in terms of understanding what the concept is and what the framework is all about. But just to go straight to the point, to quickly address one concern, was in the area of, the IDSR, how 717 aligns with IDSR. So like rightly stated, IDSR, 717 is actually here to complement 717. 717 is here to complement IDSR. In the IDSR, if you look at it, you might not, for the detection component or metric, you might not have a clear target for when a public health event is expected to be detected. And detection here is referring to from the date of emergence, which is date of onset of the illness, to the date where the public health system suspects a particular public health event. So the key word here is suspicion. And this is to increase the sensitivity of the public health system. So we don't really have to wait until we confirm in the laboratory before we say detection is done. And that is why earlier there was a mention of the response component where confirmation is done. So the moment we suspect, then that is where we say detection is done. And then we send the samples to the laboratory for confirmation. So that is not actually very clearly stated in terms of target in the IDSR. However, in the IDSR, we have a target for notification, which is particularly for epidemic-prone diseases that you quickly notify immediately as soon as you detect that event. So it's there 24 hours or less. And then for response component, what you have, you actually, in the IDSI, is 48 to 72 hours to deploy a team for investigation or for response. So beyond that, 717 now tries to delineate specific early response actions that are tailored towards quickly mitigating and controlling the spread of the outbreak before it overwhelms the public health system. So with this, I just wanted to clarify that, and then also appreciate your effort towards trying to scale up the implementation of 717. And we are also ready to support where we can. Thank you.
Thank you very much. Well stated, and thank you for the contribution. I'll go in the chat room. There are a lot of questions. Shall try and respond to them. I think, Kapaya, you will take one. It's in French. You will take that one at a later stage. Also, there's one on the dissemination plan of the study. Dr. Cynthia will take that. Likewise, there was a question, who is responsible for ethical application through local research ethical committees in our respective countries? Dr. Cynthia will take that. And then I think there is one, I think most of them have been answered. There's one where Venus is asking that who defines the baselines? I do not clearly understand what baselines is meaning, but I think his meaning is referring to the timelines here. And I think the others have been answered. So let's have those responded to as we come towards the conclusion. Let's begin with Dr. Kapaya and then Dr. Cynthia.
Dr. Alan, which one is in French?
There's one which is in French where you ticked and you said you want to answer it live.
So basically what I wanted to answer live is the question where they're asking how the 17 countries were selected.
Okay.
So the 17 countries, and I think there was also another question from Zanzibar over the same. It's the countries reported cholera outbreaks between 2022 to 2023. So we are just picking those countries that had cholera outbreaks. That's where the 17 is actually coming from. So if your country did not have a cholera outbreak, that's why probably it is not picked. So all the countries that had outbreaks are the ones that we are going to consider, because we are doing a retrospective kind of analysis of how the response, or how we can apply the 717 and look at how we responded to those outbreaks. Thank you.
Okay, then maybe before you go, there's one question. I think it's asking how to apply 717 in regions with endemic cholera that sometimes have peaks, epidemic peaks. I think that's the one you wanted to answer online, yes.
Yeah, so basically, So the definition of endemicity when it comes to cholera is interesting because cholera, ideally in most of the countries, it is an immediately reportable disease. So even one case. And the definition of an outbreak really for cholera is when you have a confirmed case with evidence of local transmission. Now, maybe the answer would be in endemic countries, they tend to have repeated cholera outbreaks, one after the other. So it's to know when one outbreak has ended and when the next one is actually has started. So that's how you will be able to determine the timelines. So there will be declaration of end of an outbreak, and also there is declaration of the beginning of an outbreak. But also broadly to indicate, usually you tend to have thresholds. For cholera, there is nothing like specific threshold. It's just one case confirmed with evidence of local transmission, then you have an outbreak. But if you have thresholds for other conditions, then you see if, for example, there is a rise in cases above the threshold, that marks the beginning of a new kind of outbreak. So that is how we would define. So for the sake of cholera is when you have confirmed with evidence of local transmission, you have an outbreak. Thank you.
Thank you very, very much. Dr. Cynthia, over to you.
Thank
2
you.
questions.
So many good questions. I'll try to answer quickly and all together. So in terms of the ethical question, all of the procedures being used in this project are part of the standard early action review, data collection tools, and interview process. We're really just looking at the feasibility of doing this almost simultaneously in the 17 countries. As a way to strengthen IHR core capacities related specifically to cholera, but also to improve, like we discussed, the kind of SOPs and specific plans that we could use to integrate these kind of measurements into IDSR and other tools like IHR MEF. So we are discussing with the ethics review boards here to ensure that we're not out of line in any of these, but we are adhering to the public health activities part of ethics review process. And if we want to have any specific conversations with the focal points from the countries about this, we are of course happy to do so. And in terms of dissemination, just to be brief, as mentioned in the slides, the final outcome will be a policy brief that will summarize the findings and have recommendations, some of which are already coming out from this meeting about clarification of dates, how to integrate with existing systems, these kind of things, as well as capacity building to show how to enable meeting these timeliness targets. In addition, we aim to have a publication brief to disseminate this more widely, and then of course come back to you and countries to then disseminate the results in a presentation to get feedback on the findings in the end. Again, to reiterate that all participants will be acknowledged and all focal points will have the opportunity to approve anything that's published beforehand as well. And none of the information gathered will be identifying any countries. It's all staying within WHO and MOH as part of IHR strengthening. So hope that answers the question. Thanks, Ofer.
And if time allows, maybe
Yes, Peter.
Yeah, thanks, Alan.
Briefly.
Yeah, thanks, Alan. I think this is I see great value in this. As I said, coming from early warning background, I was one of the skeptics. But if we're going to develop guidelines and SOPs now with the current emphasis on evidence-based development of guidelines and so on, I also see an opportunity here, because this is probably one of the first opportunities that I know of where we are going to look at our surveillance records to actually document how this 717 looks like from the records we have, from the data we can gather from our record so far, as in when was this outbreak that occurred in District A? When was it first notified? Was it reported within 24 hours? And did they take history, and were they able to find when the case actually first occurred, even before it was recorded? Then there we begin to work 7 bits, and then the 1 bit, and I think it would be very useful information for our colleagues, let's say work in IDSR and so on, to look at this data and this report and see how these SOPs then will be developed and aligned with IDSR as much as possible. So I think look at it as a very useful opportunity to generate some information that will support future development of standards and SOPs for both 717 and for integration with IDSR, and other surveillance system. Thank you.
Thank you very, very much. We run out of time, but I see one more hand. Simpara, you have raised your hand for long. If you can ask your last question and then we conclude. Dauda, Simpara, please ask.
Ok, merci bien pour la parole. Je suis Simpara, consultant au niveau de la République du Congo. En fait, je suis un peu confus. J'ai cru entendre que la stratégie 7.1.7 est complémentaire à la SIMR. Donc, si j'ai bien compris. Donc, mais étant donné que dans la SIMR, nous avons également la détection, la notification et la réponse. Cette stratégie ne fait-elle pas partie intégrante également de la SIMR? Je ne sais pas si je me suis fait comprendre. Ah bon. Allô? Est-ce que vous avez compris? Vous m'entendez?
Yes, we can hear you, but yeah.
OK.
Yes, we can hear you. You are breaking, but
Voilà,
I think...
je disais que j'ai cru entendre que on a dit que la stratégie 7.17 est complémentaire à la SIMR, comme horizon de pasteur stable. Donc, mais quand j'essaie de voir également, dans la stratégie 7.1.7, nous avons la détection, la notification et la réponse. Et ces étapes également sont incluses dans la SIMR. Donc, parler de complémentarité, ça me rend un peu confus. Je dirais que cette stratégie-là est inclue dans la SIMR. C'est ce que je voulais dire à vous.
Okay, thank you very much. Dr. Charles, you want to take this?
Yes, I can come in, although I missed part of the question. I was a bit late in the interpretation, but he's asking about the IDSR and the 717. If you look at the IDSR guidelines, you'll find there are what we call the core indicators. There are about 14 of them that are monitored at national level. Maybe they have increased. But inside the IDSR guidelines, there is one chapter, I can't remember which one, that now gives some granular indicators, especially like now, the first 7. If you go to the IDSR guidelines, it doesn't appear there as 7. It has 2 sets of indicators because IDSR looks at detection, looking at the community level, and the first case reaching the health facility, and then the health facility to the district, that kind of communication. So you'll find there is 2 sets of indicators there. One of it is less than 3 days. The other one is less than 7 days. While the matrix is giving just 1.7. So what I was saying is that what we need is to ensure that there is proper harmonization, because the matrix, the 717 matrix, complements the IDSR. But in terms of definition of those components, the package, that's where you may find that we need to make it very, very clear. It's not that the 2 are fighting, no. the 717 is complementing the IDSR, but we need to unpack, especially the first 7 and the other 7 for response, so that it's very, very clear to everybody what we mean by that. Otherwise, that is what I could say. And allow me just to mention one more thing that has been raised about endemicity. We all know that we are in the 7th cholera pandemic, which started in early 70s. When you look at the pattern, you'll find that initially cholera outbreaks were occurring after every about 10 years. Then that time has reduced the waves to about 5 years. And in some countries now, we are seeing the waves have reduced to 2 years, others now every year. That is like a road towards endemicity. Although we are not yet there, we still have cholera occurring in our region as outbreaks. And that's why we should be able to control, close it, as Dr. Kapaya has said. Every time there is a new one, we notify. We have not reached whereby cholera is a resident disease in our communities, like what you may find in West Bengal. If you go to West Bengal, they don't declare cholera outbreaks because cholera cases are seen throughout, because it is endemic in the communities. So our situation in Africa is not yet there, but we need to make sure that we fight a lot not to reach endemicity. Thank you.
All right, thank you very, very much for those questions. I think we need to come to an end. For those who still have a lot of questions, an opportunity to have them answered. The platform that they will advise, and we can always get back to you and respond to some of them. So, having said that, let me hand over to Robert for the next steps and guidance. Over to you.
Thank you very much. And before I call Nemo for the last close remarks, I want to call Fred briefly to speak about what we intend to do in the next 2 to 3 days as we move this along. Over to you, Fred.
Thank you very much, Robert. So, like we indicated, so we are asking all the countries, and in this case, appealing to the WCOs to help us coordinate with the countries to nominate or select the 717 project coordinators. And then you share with us the contact details by Friday after tomorrow. The contact details of the coordinators from each country. And then on Tuesday next week, we are going to have a detailed briefing with all the coordinators and at least a staff from the WCO, where we'll go through the 717 and the survey questionnaire. And probably, I think we'll also take that opportunity to try and address some of the things. And then after that, we'll share with the coordinators the online questionnaire, and then we'll give each country 1 week to fill out the online questionnaire. After that, we'll then provide a schedule of interviews per country. So that is how we shall proceed. So please, WCOs and all the countries, help us to coordinate so that we can have the focal points from each country, and you share the details with us by Friday. Thank you. Over to you, Robert.
Thank you very much, Fred. And in the chat, I have shared the email that you will send the details about the focal points to. It is ehs@who.int. Kindly pick it up from the chat, and then we will be hoping to hear from you in the next 1 to 2 days. Thank you very much. And at this juncture, I want to call upon Nimo Kando to make your closing remarks and then close the webinar. Thank you, and over to you, Nimo.
Thank you, Alan, and thank you, Robert, for the excellent moderation. So let me first thank you, all the participants, for your active participation. And I can see in the chat, Q&A, and also hand raise function. I wish we had a longer time, but we are already running out of the time as well. And I must thank the team who have been working hard to make it successful for a long time. You can see all of them on the screen. And I also like to thank all the interpretation team member who are interpreting in French, Portuguese, and English language, and also Amarathi. I only took the name of Amarathi, which that dry run actually helped a lot. So thank you so much, and all the people who are on the screen. I always fear naming individual and miss someone, so I'm putting everybody in a same thank you note. With that one, this is excellent opportunity to look at the bottlenecks of the timeliness part of the surveillance, which Peter eloquently described. And this is where we can generate that evidence, identify the bottlenecks, and that can go into the various SOPs or guidelines as well. And I know I'm a big fan of the IDSR. And one point of time when I was working in one of the South Asian countries, I was advocating an integrated disease surveillance in that country, which didn't happen. Still, it's fragmented. PPD is somewhere, malaria, TB, HIV somewhere, and then the emergency, potential epidemic and pandemic potential diseases somewhere. And to be honest, it's in my own country also. So Africa, and especially Afro region, is a trailblazer on this one. And this is also another milestone that we will build upon from this project, some evidence that can be applied not only for cholera, but other epidemic and pandemic diseases also. So, and we rely on your support and surveys, and we will share this all information once we have to this group again, and we will acknowledge your contribution as we move forward also. Just for one cholera thing, I would like to highlight that cholera is still common, and it's not only the medical problem or public health problem, because it has a lot huge vulnerability aspect also, because when we don't have a good soap and water, cholera is likely to be there. There is a conflict and the poverty, there is a challenge in the WAS and nutrition. And so we need to also look at the vulnerability component as well for cholera, and probably this bottlenecks will highlight that also. But from the public health perspective, especially surveillance, let's try our best what we can do, contribute for this public health events. So with that note, have a nice rest of the day, and I ask our Zoom team to close this webinar. Thank you all. Bye-bye.